That means, what are you going to do right now? With the patient that's in front of you, what are you going to do right now? If the question asks what the definitive management is, that doesn't necessarily mean something that you yourselves as PAs are going to do for that patient. It means, what's the final answer? What's the thing that this person needs to completely solve their problem? Okay? Does that make sense?
Oh.
Okay. One additional administrative note that doesn't apply to you all specifically, but just so you're aware. If there are failures, please fill out your paperwork. Okay? Another cohort today had a bad time on an exam. Some students in that cohort just refused to fill out their paperwork, got salty with the instructors, and expected to hear about it. Okay? So, maintain your professionalism. Trust me, I've been there. Nobody likes failing an exam, but that doesn't mean that you get to start acting like it. Okay?
That's fine.
All right. You know what? It's a training holiday. This turns on at some point. In the meantime, follow along on your own screen. All right? So, slide 2, titled Acute Cystitis and Lab Findings. Okay? Any questions about urinalysis? Specifically as it pertains to urologic questions. All right, you're not going to see anything on the test about crenellated RBCs, okay, muddy brown casts. You may see questions that involve leukocyte casts. Okay, that's an infectious process. We talked about infections extensively in the urology block. Okay, what can you expect to see on urinalysis in somebody who has an infection, generally speaking? So white blood cells. What else?
Positive cultures.
Cytesterase, nitrite. Okay. Remember, on a dipstick, you're not going to see cells, right? Because that's just a dipstick. You have to have a microscopic analysis to actually see cells. On a dipstick, you'll see nitrite, cytesterase, blood potentially, hemoglobin specifically, all right? Can you treat patients empirically in the absence of a culture? Yeah. And often you will. You're going to find yourself in situations where you're not going to have culture results. You're going to be working, sick call or in emergency department, and you don't want to send somebody home and say, just suffer for another couple of days, and we'll eventually get around to prescribing you something. You'll almost certainly treat them empirically. Get a culture. Okay? Follow up on it. Make sure that what you put them on was adequate. Okay? You will see questions on the exam about infections. Okay? Cystitis, pyelonephritis. You'll see questions about treatment options. What's the best treatment option given this situation? Okay. Go to slide 3. Okay. Title's Review. Acute cystitis. How do you treat acute cystitis? What are some options for treating acute cystitis?
Pain meds?
So you can use pain medications, bladder analgesics like Peridium for symptomatic control, but I'm talking specifically about the infection. What are some options for treating acute cystitis? Nitrofurantoin, okay? So nitrofurantoin is one that you would use exclusively for cystitis, right? You wouldn't use that for pyelo. Why? 2 reasons. 2 reasons you wouldn't use nitrofurantoin for pyelo. give you one of them. There's zero tissue penetrance. And you can't use nitro to treat phyllo because it doesn't get into the tissues. The reason it works for bladder infections is because it's present in the urine. It's excreted in the urine, and the infection in acute cystitis is not penetrating the wall of the bladder. Not in simple cystitis. Okay. What's the other reason that you wouldn't use nitrofurantoin to treat pyelonephritis? Is it bactericidal? No, it's bacteriostatic.
Ooh.
What about prophylaxis? You got somebody who you know has culture-proven recurrent urinary tract infections. What are you going to use to treat them? So an antibiotic, I heard that. Okay, good.
Let's go. Facts.
Probably won't use amoxicillin as a prophylactic.
Metro?
Say again?
Metro?
So nitrofurantoin is one that you can use.
There we go.
There you go.
Now there you go.
Keflex.
That's what I tried.
Keflex is commonly used for prophylaxis. Okay? All right. Either one of those are good options.
Just on the brain. It's too much.
What about asymptomatic bacteriuria? First of all, what's the definition of asymptomatic bacteriuria?
Yeah.
Basically, cystitis without symptoms.
Cystitis without symptoms, that's a good way of thinking of it, although it's a bit of an oxymoron. By definition, for cystitis you have to have symptoms, but yes, cystitis without symptoms. So you've got greater than 100,000 colony-forming units of an offending pathogen and no symptoms. Who needs to be treated for asymptomatic bacteria? Pregnancy. Hey, what are you going to treat them with? Amoxicillin. Because amoxicillin is safe in pregnancy, right? And you're rather limited in your other antibiotic choices. You can't give Levaquin or any fluoroquinolone. You can't give doxycycline or tetracyclines. Good. All right, next slide, number 4. Pyelonephritis. You will see this slide. I can't make it any clearer than that. You will see this slide. Okay? Now, so there's no confusion about the content of this slide. If you have somebody with pyelonephritis, note what's bolded and underlined towards the bottom third of the slide. What's the word? Plus, in addition to. Meaning that all the stuff at the bottom is a foregone conclusion. You are using those things. And if they meet the criteria at the top regarding resistance patterns, then it will be plus that. Okay? Does that make sense? All right. You're going to see this slide. And what if they're not improving? So if you let me make that question more specific. So if you opted to treat them as an outpatient and they're not improving, so inpatient, what else?
Add some thing.
So you don't necessarily have to convert them to IV medication. If you're talking about a fluoroquinolone, the bioavailability is the same, right? So it's not just saying I'm going to switch them to IV medication if they're already on a fluoroquinolone. What about doing some further workup?
Cultures.
So hopefully you got cultures to begin with, but yeah, repeat them. Especially if you know that the antibiotics you put them on were sensitive based on your previous cultures and they're not getting better. Sure, repeat your cultures. But what else? We talked about this. CT. If you treated them as an outpatient based on their clinical presentation and they're not getting better,
Yeah,
get a CT scan. What are you looking for?
An infected stone?
Potentially abscess. Any questions on that slide? Okay. Next. All right. Interstitial cystitis and bladder pain syndrome. Same thing. What is a hallmark symptom of interstitial cystitis that helps you differentiate it from, say, overactive bladder? Say it again. So pain with bladder filling that's relieved by urination. Okay. Overactive bladder, urinary urgency and frequency, doesn't usually present with pain. But if they have pain that gets worse as their bladder gets more full and that pain is relieved when they void, think interstitial cystitis. Okay? Like the slide says, diagnosis of exclusion. So you're going to rule out everything else it could possibly be because there isn't a test for interstitial cystitis, right? You're going to make sure they don't have infection. You make sure they don't have bladder cancer. Do all those things, and then the end result is interstitial cystitis. Okay? We talked about the cystoscopic findings. So if you do cystoscopy on a patient with interstitial cystitis, what are you likely to see? Hunter's ulcers. Okay. How do you treat interstitial cystitis? Pharmacology. So that's a off-label use, yes. Amitriptyline is something that's been used in the past. What else? Are there any FDA-approved medications for treating interstitial cystitis?
No.
Elmerod. Pentosan polysulfate. So know your pharmacotherapy for interstitial cystitis. All right, next slide. Stones. That's a big topic. And what I mean by that is that there's a lot of information, right? Stones, it's a big topic. So know your stone compositions. Know what's most common. Know how to treat them. Know how to prevent them. How do you prevent calcium stones?
Increase oxalate. Hydrate.
So hydration is part of it, sure. Dilute the urine. What else? If you're counseling a patient on how to prevent their stones, what are you going to tell them? Keep calcium in your diet. Yep, don't limit your calcium intake. What else?
Increase their oxalate.
Decrease oxalate, decrease animal protein. Okay, good. What else can you tell them to add to their diet? I think I heard somebody say Sprite. So diet citrus soft drinks, or alternatively, what's been better researched than diet citrus soft drinks? Lemon juice. Lemon water. Good. Because that increases the citrate concentration in their urine. And calcium complexes with citrate, that is a water-soluble element, as opposed to calcium oxalate, which is not water-soluble, which is when it crystallizes. Know your physical exam findings, know your presentation. We talked a lot about renal colic. What other urologic condition that we've discussed can present with renal colic type pain besides stones? Let me rephrase. If I tap you on the side and it hurts, pyelo. So don't confuse stones with pyelo,
I have none of this number.
or vice versa. Obviously, you can have both, right? You can have stones and pyelo. But don't see costovertebral angle tenderness and have that locked into your head that only applies to one diagnosis. It's not happening a lot, okay? How do you treat people with stones? Acutely. You're working in the ER, somebody walks in with flank pain.
Manage symptoms?
Hydrate. I heard manage symptoms, more
Pain.
specific. Pain medication.
Insects?
NSAIDs. Alpha blockers. Right? So medical expulsive therapy. Hydration. Analgesics. Alpha blockade. And possibly an antiemetic if they're having problems with nausea and vomiting. Okay? What is going to make you admit somebody who has stones?
Size? They're over.
So, size in and of itself is not a reason for admission. I think I heard somebody say fever.
Systematic symptoms?
So if they failed medical expulsive therapy, so you gave them a trial of conservative therapy and they failed it, either that means that the stone is still there. Maybe they're not symptomatic anymore, but the stone is still there. You're not necessarily going to admit them for that, but you're going to make sure they see a urologist. Okay? But if you send them home on medical expulsive therapy and they bounce back because they're having intractable nausea and vomiting or pain, then that's a reason to admit them. If they have dirty urine, if they have a fever, then that's indications for admission. What about solitary kidney? Yes. Or bilateral obstructing stones. Okay, these are your reasons for admission. Don't confuse reasons for admission with reasons for consultation. Not the same. Very frequently, you will consult a specialist for lots of different things. We're not just talking about urology. And they're going to say, do this and send them home. Have them follow with me as an outpatient. You had an indication for consultation. You phoned a friend, and they told you to send the person home. Okay? So they're not the same thing. So don't get them confused. But know your indications for admission for stones. All right, next slide. Bladder cancer. We've beaten bladder cancer to death. Right? We talked about it in the nephrology block and the urology block. So what's your classic index patient?
Smoker.
Smoker. Hematuria.
Overweight.
More specific about the hematuria.
Painless.
Painless hematuria. Is there a predilection based on sex?
Yes.
Who's got the higher incidence?
Males.
Males. Age range?
18 to 35?
That's testis cancer.
The numbers are they're in the wrong
Old.
spot, but they're there.
Old. Average age diagnosis is 69.
69.
Okay? So old, male, smoker. What are some other environmental risk factors besides tobacco exposure? So fuel, dyes. If you had to apply a organic chemistry term, what would that organic chemistry term be? when you have a ring made of carbon, it is called a what? So it's hydrocarbons, if it's got hydrogen attached to it as well. Aromatic. Aromatic amines. Okay, so that's what they're getting exposed to if they work with textile dyes, paint thinner, benzene, petroleum oil and lubricants. Okay, aromatic amines. How do you work up somebody with bladder cancer that you suspect has bladder cancer?
Biopsy.
So if you find a tumor, you're going to do a biopsy, yes. But how are you, as a primary care provider who sees a patient, how are you going to work them up?
Refer.
So physical exam, labs, what are
Refer
the
to
labs going to
urology.
be? UA. What lab does the textbook say you're supposed to do, but I told you not to do? Cytology, that's part of the workup. Yep, don't do it. What is something that's part of the workup that you are going to order but not perform? So that's a consultation. You don't really order it, but yes. So cystoscopy is part of the workup. And I heard somebody say one. So ultrasound is one. Okay. So based on their risk factors, okay, based on their risk stratification, and I'll be upfront with you and tell you right now, you're not going to get a question about the AUA risk stratification on this exam. You've already seen it. I'm not testing it again. Okay. What's the other imaging that you're potentially going to get? CT urogram. Yep, CT urogram. So it's not just a CT abdomen pelvis. It's a very specific CT abdomen pelvis, CT urogram. And if they can't tolerate contrast, it's eventually an MR. Yeah. So that's how you're going to work up suspected bladder cancer. And you're going to refer them to urology, not nephrology. Refer them to urology. Okay, because we're the ones that do cystoscopies. Okay. Any questions about bladder cancer? All right, testis cancer. We've already established that the age of primary risk or highest risk is 15 to 35. Okay, it's a young man's cancer. You will see it. What is the classic presenting spectrum for painless mass?
Gynecomastia.
So they can have gynecomastia, but the baseline presentation is going to be a painless testis mass. Usually noted by the patient and not by a provider doing an exam. Right? They come in and say, there's something wrong with my testicle. Expect patients to come in with testicles that are already, or a testicle that is already quite large, because they've been literally sitting on it, waiting for it to go away, get better, and had them. So they come in, they say there's something wrong with my testicle, you examine them, you palpate a mass. Now what do you do? Labs, HCG, what else? Ultrasound is not a lab, but yes. I would argue that you're probably going to get the ultrasound first to make sure that the mass is in the testicle and it's solid and it's suspicious for testis cancer. But so then you get what are those labs called in the general category? Tumor markers. You've got HCG. What are the other tumor markers? Alpha fetoprotein and LDH. Yes. And what intervals are used when you're talking about rechecking those tumor markers? Generally speaking, I'm not asking you for a time frame. I'm not like 6 months. No. What's the interval for checking tumor markers? We've already established one of them is before, during, and after. Yes. Because you want to make you're monitoring for treatment response and evidence of recurrence. Okay. What are some risk factors for testis cancer? Radiation exposure, Cryptorchidism.
Do I have to know?
This is one condition where smoking is not a risk factor. There probably, well, I shouldn't say that. I was going to say there probably aren't that many 15-year-olds smoking, and their incidence is high, but there probably are a lot of 15-year-olds smoking. Tobacco exposure is not a risk factor for testis cancer. Okay. The radiation, cryptorchidism. Technically speaking, gender is a risk factor because you got to have testicles to have a testis mass. Okay. And how do you treat it?
Spit it out? Surgery?
So from your foxhole, yeah, the answer is I'm going to refer them to urologists, right? But then how's a urologist going to treat it? What do we do for testis mass?
Surgery? Remove the testicle.
Take the testicle out. By what route? Do we go through the scrotum? No. Why don't we go through the scrotum? Because of the lymphatic drainage. If you have tumor spillage, now you're in a much harder place when it comes to providing them a durable cure. So yeah, it's an inguinal incision, do the inguinal canal, deliver the testicle up. What is also often used as adjuvant therapy for testis cancer? Radiation and chemotherapy. So depending on tumor stage, whether or not they already have metastatic disease, whether you're concerned that they have metastatic disease that you just haven't been able to visualize yet, then yes, you'll potentially do adjuvant therapy. You know, remember we talked about Lance Armstrong, you know, who had a brain met. He had chemotherapy and radiation. So they radiated his head and they gave him platinum-based chemotherapy. So that's how you're going to manage those patients. Oh yeah, and screening for testis cancer. Is there any indication for the medical community to do screening for testis cancer? No. You just tell patients that they need to do self-exam. All right, next slide. What is priapism?
Erection lasting longer than 4 hours.
An erection lasting longer than 4 hours. Time frame is important. If it's been less than 4 hours, it's not technically priapism yet. Okay. Also, it's usually a painful erection lasting more than 4 hours. When is it not painful? So if it's the result of a spinal cord injury, it might not be painful then, both because of the mechanism of action and maybe they're paralyzed. Their sensory inputs and outflow are terminated by the spinal cord injury, so they just can't feel it. Okay, when is another time that it's not painful? Let's back up a second. What makes it painful when it is? So I heard somebody say AVM. Are you giving that as an example of when it's not painful? Oh, ischemia, yes. Ischemia is the reason that it's painful. So when is it not painful? When it's non-ischemic. So if they have high flow priapism, which is usually the result of an AVM. So after some sort of pelvic trauma, we can end up with a partially or fully rigid penis that isn't painful because it's the result of high flow of heavily oxygenated arterial blood into the corporal bodies. Okay? How can you differentiate between the two? We've already established that one is usually painful and one usually isn't, so I'm asking about something else. How else can you determine which one it is? So I heard somebody say Doppler. You can use Doppler ultrasound. That requires a ultrasonographer who's relatively skilled at doing penile ultrasonography, which you're not necessarily going to see at a smaller facility. But what's something you can do? What does this mean? So on physical exam, you might be able to discern something, but that's very subjective. There's a much more definitive way to differentiate between ischemic and non-ischemic.
CT?
Not CT. Please don't CT somebody with priapism. Please don't do that. That is the wrong answer. I'm going to make that a distractor on CT penis. Okay. But you're in the right ballpark as far as like evaluation outside of physical exam. Does arterial blood and venous blood, do they look different on laboratory evaluation?
Yes.
Yeah. So order penile blood gas.
That sounds
Stick
more
a
painful
needle
than
in
a
the corporal
CT.
body, draw the blood off, send it to the lab. Does it look arterial? Probably high flow. Does it look old and sludgy and acidotic? Probably ischemic. Okay? Penile blood gases. How do you treat priapism? Actually, hold on. Hold that thought. Back up. What causes priapism? So we've established that spinal cord injuries can cause priapism. We've established that pelvic trauma can potentially cause high flow priapism.
Drugs can.
Drugs. Give me some drugs that cause priapism.
Viagra.
Don't actually give me drugs that cause priapism. Name some drugs that cause priapism.
Viagra.
Viagra. Any PDE5 inhibitor can potentially cause priapism, although it's relatively rare. But it can happen.
That
What
one-
else?
The one that you put in. Like a
What recreational substances can cause priapism? Cocaine. The yayo. Yes. Tony Montana. The vast majority of cases of priapism that I've seen in my practice outside of the military when I was in training in the civilian sector were the result of cocaine use. What is another medical condition that can cause ischemic priapism? Sickle cell. Yes. And to treat that, you got to manage their sickle cell crisis, right? In addition to managing their priapism. Okay. Now, let's go back to talking treatment. So for sicklers, you're going to put them on oxygen, right? And see if that works. And if it doesn't, then you're going to get further down into the treatment algorithm that applies to everybody with priapism, which is what? So irrigation, drainage. What about pharmacologic therapy? Alpha agonists, specifically phenylephrine. And how do you administer it? Is it VO? It's injected directly into the corporal body. Is that correct? You only have to put it in on one side, right? Because the corporal body is communicating. I am not going to ask you about dosing strengths for phenylephrine for priapism, but it's a good thing to know, especially if you find yourself in a rural area, you don't have quick access to urology. There's a chance that you can potentially take care of patients on your own without having to, call an ambulance or a helicopter. Torsion. What is torsion? I'm waiting for an answer I can hear.
We're nervous.
All right, so it's twist, but technically it's a twist if it's rheumatic soreness, right? So there's a kink in the hose. What are some physical exam findings for somebody with a torsion? High riding testicle, lack of a cremasteric reflex, Say again? So it's not pain when you lift it, it's lack of relief. So if they have relief of their pain when you lift the testicle, that makes torsion less likely, but it doesn't rule it out. And you can't hang your hat on Bren's side. Okay? But it is something that you should look at when you're examining somebody. So in addition to the testicle being high riding, what also is usually abnormal about the testicle position? So it has a lateral lie. So instead of it being like an egg that's hanging with, narrow point up, wide point down, it's turned 90 degrees. So imagine an egg laying on its side. Okay? That's a lateral lie. Okay? Do they often have external physical manifestations? Can they have redness, swelling? They can. So it can be confused with epidermolysis. How do you confirm the diagnosis? Doppler ultrasound. Yep. That's how you confirm the diagnosis. How do you treat torsion?
You can try manual first.
You can try manual detorsion. Please make sure that you have the ultrasound before you do that. How do you manually detort the testicle? Open the book. The vast majority of torsions happen with the twisting occurring medially. So if you twist the testicles laterally, don't twist both of them. I know we keep talking about opening the book and we do both hands like this. Only try to detour the affected testicle.
I want to know.
You don't want to fix one and twist the other. Okay?
Yeah.
When we're talking about opening the book, it's a matter of perspective, okay? You're looking at the scrotum, the median raphe is the center of the book, and you're opening it outward, but only do it to the affected testicle, please. But know that you can have torsions that occur with a lateral rotation. So it is possible that in your efforts to make the patient better, you're actually making them worse. Okay? There's no way for you to know that. It will be a clinical diagnosis based on the fact that they get worse and not better when you try to open the book, in which case close the book. So that's how you might manage it at the primary care level. But what is the definitive management for torsion? More specific than surgery. More specific than orchidopexy. Bilateral. Because why did they get a torsion? They have an abnormal or absent fixation mechanism, right? Their gubernaculum is either hanging someplace it's not supposed to be or it's completely absent. Which gives them what deformity? Bell clapper deformity. Yes. And if they have it on one side, very likely they have it on the other side. So definitive management for torsion is a bilateral orchidopexy. Okay. Scrotal masses, we already talked about testis cancer, right? So any questions on testis cancer as far as scrotal masses are concerned? Okay, what are some other scrotal masses that you can see? Hydrocele? Varicocele? Okay. How do you evaluate a hydrocele? So you can do transillumination. Please don't use the ophthalmoscope or the otoscope in the exam room to transilluminate a scrotum. Have a dedicated light source for that. Also, whatever dedicated light source you have, so after we had this lecture, the subject came up among the faculty in a completely unrelated forum. Make sure whatever ancillary light source you have is something that doesn't generate a lot of heat. One of the other faculty told me that they were training medics on transillumination, and they thought it would be a great idea to try it out with a Surefire light from a rifle. Surefires get hot, and they decided that they were going to practice transillumination on each other, cosmetics, and they got burned scrotums. So make sure you're using something like a medical grade pen light. You don't have to worry about burning somebody. Okay? If it's all you got access to, great. Just be cognizant of the fact that it can get warm. Okay. So after transilluminating, what's the next thing you can do to work up a scrotal mass? Ultrasound. Ultrasound is the gold standard imaging modality for anything scrotal. Okay, gold standard. Just like there's no CT penis, there's really no CT scrotum either. Okay? I mean, if you order a CT abdomen pelvis, you're gonna get the scrotum in those cuts that go down through the lower part of the pelvis and the proximal thighs, but it doesn't really tell you much. Now, if somebody's got an enormous mass, obviously that's going to show up, but there's no role for CT in say diagnosing a testis mass, like suspected testis cancer. It's always going to be ultrasound. Okay, ultrasound is the gold standard. Okay, so you've done an ultrasound. You've diagnosed a varicocele. What are some red flags that you need to be concerned about with varicocele? Right-sided. If you find somebody with a right-sided varicocele, what are you going to do? CT abdomen pelvis. Make sure they don't have something obstructing their venous drainage proximal. Very good. Okay, so for infectious processes, remember to differentiate between sexually transmitted concerns versus non-sexually transmitted concerns. What's your age threshold for saying I'm going to, by default, consider this person to be at risk for sexually transmitted infection? 35. So if they're under 35, don't trust them. I'm not saying you should. Telling you in clinical practice, you're going to just treat them. You're like, okay, fine, you say you haven't been with any new partners and your partner hasn't been with any new partners, but I'm going to treat you anyway. So what do you give as part of your specific treatment regimen for covering those sexually transmitted organisms? Doxy and Herceptin. Okay? And then your additional treatment is going to be driven by what you suspect might be going on in the background. Again, what's the most common organism that causes urinary tract and genital infections in men? Most common urinary tract infection organism, also most common cause of genital tract infections in men that's not sexually transmitted. E. coli. Yeah. So you're most likely going to be covering coliforms, but obviously you can have other weird things. But remember to cover for both if they're under 35. Okay, so prostate conditions. You will see questions on prostatitis. You will see questions on BPH. You will see questions on prostate cancer. Okay? How do you treat BPH? Alpha blockers and or so that's a surgical option, but what's another pharmacotherapy option? Alpha blockers and or 5-alpha reductase inhibitors, right? Finasteride or dutasteride. What situation clinically would you consider a 5-alpha reductase inhibitor as your first line treatment? So we already know the patient's got BPH symptoms. Also, let's back up 1 second. Technically speaking, how do you diagnose BPH? Technically speaking.
History?
Not ultrasound. It's ultrasound guided. Right. So BPH is actually a pathologic tissue diagnosis, but we never do biopsies to confirm the diagnosis of BPH. It's a clinical diagnosis. Okay? But know that. Invariably, you're going to have somebody tell you that on clinical review. Actually, BPH is technically a pathologic diagnosis. To know that somebody has prostatic hypertrophy of the cells, you have to actually look at the cells under a microscope. Okay? But again, we don't do that. It's all based on physical exam. So, you're treating a patient symptomatically, right? It's based on their presenting symptoms. They filled out an IPSS score. They came in and said, I have problems with weak stream, nocturia, I'm miserable. What is an indication for using a 5-alpha reductase inhibitor as your first-line agent to treat their symptoms? What do 5-alpha reductase inhibitors do? Second? No, that's PE5 inhibitors. 5-alpha reductase inhibitors for BPH.
I know it like inhibits.
So it prevents the conversion of testosterone into dihydrotestosterone, which does what? Shrinks the prostate. So if your goal is to shrink the prostate, what do they have to have in order for you to want to shrink it? It's got to be enlarged. What's the threshold for giving a 5-alpha reductase inhibitor as your first-line treatment? 30 cc's. Okay. You would not use a 5-alpha reductase inhibitor for somebody as a first-line treatment for somebody with BPH symptoms if their prostate volume is less than 30 cc's. Talk about alpha blockers. I mentioned some of the symptoms of BPH. What are some other symptoms of BPH? So I said weak stream, nocturia. What else might you see with BPH? You could see UTIs, yes. Yeah. What else? So weak stream, hesitancy, intermittency, meaning they get the stream going and it tapers off and they're not done and they have to get it going again. Okay, nocturia. Potentially you can see urgency and frequency, but they can also have OAB, right? But primarily your BPH symptoms are going to be ones that are obstructive in nature. If you have a young male patient who presents with obstructive symptoms, what are you going to think about? If they're young, do they likely have BPH? No. So what causes obstructive symptoms in a young person? I think I heard it. Say it louder. So that's what causes the problem, but what does the STI result in? Urethral stricture. So if you see somebody who is young, oh, and by the way, strictures can happen in women, but it's extremely rare. Extremely rare because of just the short amount of real estate, right? There's not a whole lot of room for urethral stricture disease to develop, so it usually doesn't. But yeah, so young male, especially if they have a history of sexually transmitted infections, usually gonococcal, but it doesn't have to be. Think urethral stricture. Prostatitis. How many categories of prostatitis are there? 4. Okay. You've got acute bacterial, chronic inflammatory, chronic non-inflammatory. Be able to differentiate between those different types of prostatitis. Okay. There was a chart in the lecture slides that shows the breakdown, how to differentiate between them. Know the chart. Okay. Prostate cancer. I am not expecting you to be urologists or oncologists or anything like that. So you're not going to see questions on the exam about prostate cancer management. There's no questions about surgery, there's no questions about chemotherapy, there's no questions about radiation for prostate cancer or anything like that. What I need you to know as PA is how to identify it, what should set off warning bells in your head, and what do you do next with it? Generally speaking, if you have concerns, what do you do next with it? Refer to urologist. Yeah. But know what those warning bell elicitors should be. Okay? Who wants to take a 10-minute break? Anybody? Or you want to keep going? Keep going? Okay. Yeah, so know the screening guidelines for prostate cancer. Okay. So know who should be screened, when they should be screened, and what should make you concerned. Okay. The next slide is the prostatitis chart for your reference. After that, ED. What are the types of ED, generally speaking? Psychogenic and organic, right? So it's either a brain problem or it's a vascular problem, generally speaking. Okay. How do you differentiate between the two? History is a very, 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 very strong part of it. Nocturnal erections. So if you're not able to make the determination, or things don't add up, if the picture isn't clear, then you can do nocturnal tumescence testing. But if you can ask the patient about it and they can say, yeah, I wake up with erections, then you don't need to do nocturnal erection testing. How do you treat psychogenic ED? CBT. You are never going to forget that. Yeah, so a behavioral health referral should be part of the. Oh, by the way, I don't know if y'all heard this. I just learned this yesterday. Apparently, we're not calling it behavioral health anymore by order of the Department of War. It's now mental health. All of the signs and all of the facilities have to be changed. Okay. I don't know the reasoning behind the determination. I just know that they're changing all the signage in all DHA facilities. It's no longer behavioral health, it's mental health. Okay? Good luck breaking yourselves with that terminology change, because I had to do it in reverse. When I started training, it was mental health. And I had to learn to say behavioral health, and I'm going to have to learn how to go back again. So, behavioral health, mental health referral. Okay? What else do you do to treat patients? PDE5 inhibitors. So you can give them PDE5 inhibitor. It doesn't have to be reserved for people with organic disease. Sometimes people with psychogenic ED just need a little boost. They just need a little confidence improver to break that cycle that they're in mentally and help them get that problem resolved. I've done this a lot. Prescribing ED meds to very young patients, and I've oftentimes had to justify it to the pharmacist. They didn't want to dispense the med. He's 18. Yeah, well, I'm a urologist. Listen to me. There's good reason for this. I'm not just giving him recreational drugs for his weekend. So PDE5 inhibitors for organic ED also, right? What if PDE5 inhibitors fail? What are some other treatment options for ED? What used to be the gold standard? Alprostadil, which can be administered by what two routes? Injection or pellet in the urethra. Okay. So they fail PDE5 inhibitors. they fail injectable therapy and or urethral therapy. Now what do you try? Not quite there yet. Vacuum erection device. Okay. Remember Austin Powers. It really was his bag baby. Okay. And then if they fail vacuum erection devices, then prosthetics. Okay. Are there any ED meds that can also be used to treat other urologic conditions? Perhaps a urologic condition we've already discussed? Cialis? BPH. So if you have a patient who has both ED and BPH symptoms, you can potentially put them on daily Cialis. You will struggle getting that prescription approved, but it can be done. Why is Cialis able to be used for both indications? So it has an extremely long half-life, 36 hours. It's taken daily when it's used for the BPH application, and because it has such a long half-life, it eventually builds up to a steady state in the bloodstream, which helps with the erectile. Okay. But good luck getting Cialis prescribed for BPH alone. Also, does Cialis actually improve objectively measured urinary function levels like strength of stream, emptying, all that? Nope. It just makes their IPSS satisfaction score better. Okay, Peyronie's disease. What's Peyronie's disease? Louder? So it's a plaque causes it, which results in what? Angulation of the erection. Yep. So while the penis is flaccid, it's usually not a problem. Although you can have plaques that are circumferential around the corporal body and cause a narrowing unilaterally. But for half of the penis, they can have like a band. But most of the time, when the penis is flaccid, Peyronie's disease isn't a problem once it gets through the acute phase. When it's still in the acute phase, the plaques can be painful to palpation. Okay. What causes Peyronie's plaques? The short answer is there are theories as to what causes Peyronie's plaques. Prevailing one being microtrauma, repeated microtrauma in the same area. But remember, I told you that you can have somebody who has a penile fracture who doesn't develop Peyronie's disease. In fact, most of them don't develop Peyronie's disease. So it puts some question on the trauma mechanism. But that's the prevailing theory. Histologically speaking, Peyronie's disease, the plaque is disorganized collagen. Right? So something caused the collagen in that area to be laid down like think about, you know, somebody who does knitting and they've got a basket full of yarn and all the balls are well organized, and then the basket gets knocked over, a cat gets in it, and now the yarn's all tangled up and it's not organized anymore. That's what happens. The collagen gets laid down in a disorganized fashion. So how do you treat Peyronie's disease? So intoxifiling was a off-label use that has been used in the past. Yes. So Xiaflex is the brand name, which is a whole lot easier to say than Clostridium collagenase. But yes, so the collagenase dissolves the plaque And for whatever reason, when the body relays that collagen down, it does it in an organized fashion. It's no longer disorganized. What if they're not a candidate for injections, either because the plaque has calcifications in it, or it's located too close in proximity to the urethra? What else can you do to treat Peyronie's? I think I heard somebody say that. So we're past injections. Surgery. You can either excise the plaque and graft it, or you can put in a penile prosthesis. Because the penile prosthesis is robust enough that it will straighten the penis out and overcome the curvature from the plaque. You can also do a penile plication. And again, the downside to a prosthetic and a plication, well, with the prosthetic, in addition to being completely dependent on a prosthetic for the rest of their lives, it also causes some foreshortening of the erection, which also occurs with plication. Any questions on Peyronie's? Okay, incontinence. Failure to store, failure to empty. What is stress incontinence? Coughing, sneezing, raising intra-abdominal pressure. It's leakage with stress maneuvers. It has nothing to do with physiologic stress. It's you do something that causes straining and results in urinary leakage. So what's urge incontinence? Correct. So they have a sudden urge to urinate, and they can't arrest it, and they leak. If they have a sudden urge and they don't leak, do they have urge incontinence? No. But they probably have overactive bladder. Can you have stress and urge incontinence at the same time? Yes. What is the fourth category of incontinence that we just haven't mentioned yet? So you've got stress, you've got urge, you've got mix, and you've got so total incontinence is that's not really a category of incontinence, but it's one of the questions that you ask when you're talking to patients as part of their workup. Do you leak all the time? Is it situational? There's actually there's a category of incontinence that we haven't talked about. Overflow incontinence. Okay. Which may be total, it may not be. Okay. So overflow incontinence, they've just reached maximum capacity. They can't void their bladder for some reason, and they're just leaking urine. Okay. How do you treat incontinence? What is your first line treatment for stress or urge incontinence? So Kegels for stress, but as a general category. So you're in the category, but you're naming parts of it. So lifestyle and behavior modification. Okay, those are your first line treatments. Kegels for stress incontinence, weight loss, physical fitness. These are the things you're going to try first before you get to pharmacotherapy. What is becoming the first line pharmacotherapy class for urge incontinence? Beta-3 agonists. Beta-3 agonists. What did we used to use as the first line treatment? So oxybutynin is one of them, but what category is that? Antimuscarinics. And the reason they're falling out of vogue is what? Increased risk of dementia. Increased risk of dementia. Okay? A lot of places you're still going to be expected to write for an antimuscarinic first because the beta-3 agonists are so new, they're very expensive and have to fail antimuscarinic. What's becoming the preferred first-line pharmacotherapy for overactive bladder urge incontinence is beta-3 agonists. Is there any pharmacotherapy for stress incontinence? No. There's no pharmacotherapy that has a direct impact on stress. So if they fail conservative management for stress incontinence specifically, if they fail conservative management in the form of behavior modification, pharmacotherapy, what's next for them? Surgery, right? So they might have a mid-urethral sling, they might have a sacral colpopexy, depends on what's causing their stress incontinence in that situation. For urge incontinence, if they fail conservative management, they fail pharmacotherapy, oral pharmacotherapy, what can you do for them after that? So you could theoretically put a catheter in somebody, they won't like you for it, and you can't leave it in long term. They'll get infected. But it's an option. It's not a great option, but it's an option. What was that? Are there non-invasive options for treating urge incontinence? So you don't want to use Kegels for urge incontinence, it'll make it worse. Botox is one, but before Botox, what's something else you can try? So pessaries are for stress. Good. Pessaries are for stress. So for urge, a non-invasive option is percutaneous tibial nerve stimulation. Okay. And then the invasive version of that is interstim or sacral nerve modulation by an implanted generator that goes under the skin of the buttock. It has leads that go down into the S3 nerve foramen. And then absolute last resort, diversion or taking their bladder out or doing an augmentation, depending on what their underlying problem is. Okay. Infertility. Last thing before we get to the slides that are questions. Infertility. What is the cornerstone of working out male infertility? Semen analysis. Okay. How long does a couple have to engage in unprotected intercourse before you decide that they have a fertility problem? 1 year. 1 year. Does their prior fertility history have an impact on that? Yes. So if you have somebody if you have a couple that have prior success with fertility and now they are not having success with fertility, then you can potentially move up your timeline. What's another reason for moving up your timeline? Maternal age. What's the threshold? 35. Yep. Okay. So semen analysis is the cornerstone. Time frame is a year, unless they have mitigating factors which would make you do it earlier. Right? What are some things that you tell patients who are having issues with infertility, just by way of counseling? How often? So making sure that if they're trying to become pregnant, making sure that they're having intercourse frequently enough. What are some things you're going to tell them to not use? Spermicides. Also, more generally speaking, lubricants in general, right? Because even a non-spermicidal lubricant can interfere with fertility. I didn't say this in lecture, and it's not going to be on the test, but I swear to you, this is true, and you will see it. There are people who will come in and say that we've been trying to get pregnant and we're not having any success, and you'll find out that they're using condoms. Not kidding. So Sometimes it's not sufficient to ask the patient if they're engaging in unprotected intercourse. They may not know what that means. You might have to spell it out for them. Okay? And I can guarantee you will find yourselves in situations where you are having to resort to common vernacular to get your message across. Okay? If you have to ask a patient if they're raw dogging it, you might have to do that. Okay? And I'm not saying that to be crass. This is real life. Okay? You take for granted the level of education that you have. And I say that because I take for granted. There are things that I take for granted that I think should be common sense that everybody should know, and not, okay? So make sure that they are truly engaging in unprotected intercourse if they're having issues with fertility. Okay? You might also find that they're having unprotected intercourse, but they're using an incorrect orifice. And that's why they're not getting pregnant.
What's that for you?
Uncomfortable questions that you have to ask. Okay? And I said it the way I said it for a reason, because there are multiple incorrect orifices when it comes to reproduction, as far as fertility is concerned. So don't take it for granted that patients know what you're talking about. Make sure you break it down Barney level. Purple crayon it for them. Okay, so that's all the review slides. Okay, everything else is questions. There's not nearly as many as there were on the nephrology review deck. There's only 18 more slides, 18 questions. Okay, and it's pretty much going to rehash all the stuff that we just talked about. So we still don't have a projector that's functioning. Try this one more time. Nope, it still says it's powering up. Cool. I can go through the slides with you, but the correct answer is in the notes, so you're going to see it. So I don't know that it's really beneficial, and I've already kept you over from a break. So unless anybody has any specific questions for me, I'll give you your time back. For everyone who talked to me about wanting to discuss the exam after the review, if we can do that now, that would be great, because they added on a meeting for me at noon that I wasn't anticipating. So if you wanted to talk to me after lecture, come to my office now. Otherwise, have a great afternoon, enjoy your weekend, and don't stress about Tuesday. I swear I'm not lying.
Yeah.